Hello.
Yes,
Yeah, sir, we are live now. You can start with the session.
share the slides then.
Yes.
Okay. So, good afternoon, everyone. Myself, Dr. Manoj Toshniwal, working as hematologist at Jeevan Amrut Hospital, Aurangabad, Maharashtra. And today we are discussing management of anemia. So, today's uh, session is what goes by Med Talks. Anemia is a broad topic actually, so that is why I just restricted it to mainly newer iron molecules. So that we can get an insight what is happening in anemia management. First of all, I thank every one of you and specifically the Med Talks to arrange this talk today. And all of you who are busy in OPD but still managed somehow to take some time out and come here to discuss some scientific. Thank you so much from me. I'm not someone who is expert. You all are expert. You have all your busy OPDs. Many people are there who are standing in queues for you to treat them. I know a little bit more about anemia. That is why I'm delivering the talk. So, if at all in between also you have any questions, any suggestions, anything, please feel free to ask or type that question in between in Q&A box so that it can be more dialect rather than just a lecture. So anemia is very broad term. Anemia is not the disease itself. It is a manifestation of something. It can be because of any reason. So most important part in the management of anemia remains the find the cause. What is the cause of anemia? You all know anemia is low hemoglobin. Whenever hemoglobin is lower than the normal, we call it as anemia. If WBC count is low, it is called as leukopenia. If WBC count is high, we call it as leukocytosis. If platelets are low, thrombocytopenia. Same is about erythrocytes. When they are low, it is erythrocytopenia, that is anemia. And when erythrocytes are a higher side, we call it erythrocytosis or polycythemia. So anemia is when hemoglobin is lower than the normal, and it can be because of n number of causes. So to treat that particular disease is most important. My boss used to say anyone can treat, but only few can diagnose. Diagnosis remains the most important. You see a patient of anemia, you give them 2 units of packed RBCs, and it is treated. Hemoglobin becomes 13. But that's not the way. Why someone has developed that anemia? That root cause has to be found out, and to treat that, that means you have treated anemia right. And that is why it is very important to see that blood counts completely. We see that CBC report and we are in always rush, hurry. We see hemoglobin is 8, we just scribble down HB14 or Oro4XT or Levogen Z and we tell that patient ek mahina gaya, barat gaya. We have not thought that why someone is hemoglobin low. What can be the cause? What needs to be done to eliminate it permanently? And there lies the problem. You will be astonished to know that almost more than 50% of Indian women in reproductive age group are anemic. And anemia is third stage of actually iron deficiency. Whenever there is iron deficient erythropoiesis, patients start developing symptoms. So if we take iron deficiency per se, we can say that more than 80-90% of Indian women are, and there lies the main problem because we don't pay attention to what is the cause of that particular anemia. And that's why today's lecture is there, management of anemia. So first step in management of anemia is find the cause. By doing that, CBC, it is not sufficient. reading that CBC properly, that is what is needed. As nowadays, we have got many newer machines. These are automated counting machines which give far more information about the various blood parameters. And that is why to read them completely is something which is needed. They give us MCV, MCH, MCSC, also WBC count. In WBC count, various parameters, platelet, various parameters. And that is why we should read it completely. This is the routine hemogram which comes. It is 3-part filter which gives a lot more information. Now we have this 5-part, 6-part automated counters which can give us a lot many parameters to be studied. So it is hemoglobin. Along with that, RBC and hematocrit just part of hemoglobin value only. If hemoglobin is low and still RBC count is good, we can say that patient might be suffering from some hemoglobinopathy. Thalassemia minor can be there, and that is why whenever we see low hemoglobin value, first thing to note is whether RBC count is normal or low. If along with hemoglobin being low, RBC count is also low, that means patient is having erythrocytopenia, that is anemia proper. Then look for mean corpuscular volume, MCV, and other parameter, MCH, MCST, RDW, and also throw some light on your WBC and also the platelet count, which can be abnormal as well. So these are the main parameters which one need to see, and these are less known parameters about particularly absolute retic count, reticulocyte percentage, immature reticulocyte fraction. It gives marrow functioning as well. Many times I get a call that patient is anemia, come for a marrow, and we see that reticulocyte count is good. If reticulocyte count is good, that does mean that your factory is working. Your cells are getting produced. There is no point in doing bone marrow in such cases unless we are looking for something else like paroxysmal nocturnal hemoglobinuria or some other disorder associated with autoimmune hemolytic anemia, then only. Otherwise, it is usually because of the increased destruction of cells. So reticulocyte count can also be a good thing to see whether that patient is having anemia due to which reason. Manual microscopy is very important because it gives us the information about morphology, size, color, shape of the RBC, and many of the diagnosis can be made on just seeing the smear. It also gives us the confirmation about WBC and platelet as well, and also see whether some abnormal cells are there. And so that is why reading that value completely is very important. As we have already discussed, whenever there is RBC count is in normal range and still anemia is there, patient can have thalassemia minor, and that is why we deduce that Menzer index from MCV upon RBC count, and depending upon that, if needed, we go for HB electrophoresis or HPLC to confirm the diagnosis of hemoglobinopathy. Hemoglobin normal value is around 13 to 17 in males and 11 to 15 in females, depending upon various ethnicity. But MCV is very important parameter. Whenever MCV is low, we call it is microcytic anemia. If it is high, it is macrocytic anemia. But it is common in our country to see normocytic anemia because it is usually dimorphic. Someone is most common cause for anemia in India is nutritional deficiency. And in that, if nutritional deficiency is there, it is less likely that someone is having only iron deficiency or only vitamin B12 deficiency. Usually it is dimorphic, and that is why normocytic anemia is MCH gives us about value of your what you call hemoglobin percentage in particular cell. So if it is decreased, we call it as hypochromic. So microcytic hypochromic anemia, normocytic hyperchromic, macrocytic hypochromic, such type of classification can be made on that. So if whenever it is less, we need to see microcytic, macrocytic. MCSC is very important, particularly in patients who have hereditary spirocytosis or even autoimmune hemolytic anemia cases where many spirocytes are in the blood. because it is derived from Hb upon hematocrit, and it is usually more than 35. If more than 35 MCSC is there, we can suspect patient might have hereditary spherocytosis or even autoimmune destruction of the hemoglobin or RBC. So depending upon MCV, we can say microcytic, macrocytic or normocytic. Most commonly it is microcytic, and usually it is because of iron deficiency anemia. If adult female is there, it is mainly because of the excessive menstrual loss or nutritional causes. If adult male is there, one must look for extra loss from somewhere else, like bleeding piles or some gastric or colonic lesion which is bleeding. And sometimes we may get a malignancy earlier presenting with this MCV being low anemia. So that is why paying attention to the microcytic anemia in adult males is very important. Also, anemia of chronic disease, thalassemia, sideroblastic, these are common causes of microcytic anemia. Macrocytic anemia is common in India because of vegetarian population and overall diet being low in vitamin B12 and folate. Hemolysis and MDS can also be there. I had one patient who was having MCV 135, repeatedly given vitamin B12 but still not responding, and her direct urine test was 4 plus. Macrocytic anemia not responding to vitamin B12, one should not miss autoimmune destruction of the RBCs, which lead to the hemolytic anemia and macrocytic anemia. And normocytic anemia, as we have already discussed, it can be because of combined deficiency, that is dimorphic anemia, which is common, or also chronic anemia, the chronic anemia of chronic disease. That can also be a reason for normocytic anemia. So depending upon this initial test, one must diagnose what is the cause of anemia rather than just jumping to treat that particular anemia. Reticulocyte count is very important test. It's just 100 bucks and it gives not much information. If reticulocyte count is good, that does mean that patient has hemolytic anemia or anemia of chronic disease and marrow is functioning. But it is less, maybe bone marrow failure can be there because of the nutritional causes or some other causes. One must look into the reticulocyte count particularly. I usually say iron studies are done, but still we are not able to do iron studies rightly. Ferritin is very important test. Whenever ferritin is low, it is because of the iron deficiency anemia for sure. If ferritin is low, but still we suspect iron deficiency anemia, then we have to do the iron studies, and that needs to be done in fasting state. Patient should not be already on iron molecules and you do iron studies and you find iron level being high. So whenever we do iron studies, patient has to be in fasting value. So high TIBC and low transferrin saturation can be because of this iron deficiency. Even ferritin is good and transferrin saturation is less than, that TS is less than 20%, that is functional iron deficiency. And in those cases, particularly patients who are having chronic disease like rheumatoid arthritis, congestive cardiac failures and other, they do respond very well to the IV iron if functional iron deficiency is there. So iron is very labile molecule, and be aware about these tactics while we are doing iron studies. So let's move on to the treatment of or management of anemia. And in that, because of lack of time, today we will cover only treatment of iron deficiency anemia. First, we have seen whether patient is having anemia. In that anemia, if MCV is low, we have done the iron studies and ferritin. Ferritin is low, transferrin saturation low, iron is low. That does mean that patient is having iron deficiency. Then one must go for the treatment. But before that, also diagnosing iron deficiency anemia is not enough. Why iron deficiency anemia? It can be because of excessive blood loss, or it can be because of poor diet. One must spend some time to discuss about the diet options in anemia patients. Also ask them whether they have some excess bleeding, menstrual bleeding or GI bleeding or piles and other those things. And then only one can treat them rightly. Then in treatment, we have got three options. Oral preparations. Yes, all oral preparations more or less same. But nowadays, newer molecules are there like ferric maltol, liposomal iron, sucrosuromal iron, which can be taken 1 or 2 pills per day, and it gives very good result and less side effects. You all use this Devogen Z. It is ferrous fumarate, works best when taken empty stomach, and it has to be taken without antacids. Usually we write them uh, pantoprazole or rabeprazole along with levogen, and then it's all useless. So most people start to feel better after taking this medicine within 1 week's time, and usually start feeling better. But 70% of them are intolerant because of the GI side effects. This ferrous ascorbate is little bit better than ferrous fumarate for sure. That is oro for XT. It helps better absorption, less side effect, but it is a little bit costlier option for sure. Ferrous bisglycinate, that is bis per XT, which is available in the market, it gives very better absorption as compared to the fumarate, sulfate, and other molecules which are traditional, but it is little bit costly, and at least it should be taken uh, 2 times in a day. This lupine, that is what you call animal tissue source. Those who are non-vegetarian, yes, in those patients you can use this lupine, which is from animal tissue, better bioavailability, better tolerability, and usually it is taken 12 hourly, that is twice in a day. 12 milligram is the dose for this. And these newer molecules, liposomal or sucrosomal, can be taken once daily only, higher bioavailability and no GI irritation. So, don't tolerate oral iron, maybe these can be the newer molecules which can be given. Yes, we have this hepcidin and ferroportin feedback loop, and that is why giving more achieves less. So giving less iron usually helps in better absorption rather than increasing the dose of iron. Let's discuss with the patient whether they are taking it empty stomach, whether they are taking it properly, whether diet modification is done rightly. It should not be taken with calcium. This needs to be discussed. So, if patient is having chronic inflammation going on because of some other disease, maybe hypothyroidism, hyperthyroidism, some rheumatoid,
Hello? Hello? Hello?
अभी आ रहा है ना? I'm not sure what has happened. ठीक है, चलो आ गए तो I think I can share the screen again. Is it okay now? Yes. Yes. Am I audible?
Yes, sir.
Hello?
Even if giving the iron, patient doesn't respond to your treatment because of this feedback mechanism. And in those cases, then we need to do something else. That is, maybe we can go for the IV iron preparation. With this fast moving world where everyone is at rush, everyone wants results immediately, I find rather than waiting uh, those oral preparation to work, we can choose something from these newer iron molecules. Ferric carboxymaltose and iron isomaltosides are these two new iron molecules available to all of us. So it is mentioned that anaphylaxis, hypertension, flushing, these side effects are there. But these are fourth generation molecules, very tolerable, very less side effects, and easily given. Just one dose or even second dose maybe after 15 days, and it cures your anemia or it gives you the best result. So in those cases where you are not in position to, or you are not um,
Hello.
it okay now again?
Yeah. Your
I'm
slides
not
are
sure
visible,
why it
sir.
is happening, but let's see. We are back to normal
Yes.
quickly. So
Yes.
yes, it looks like yes. If someone has anemia which is not responding to oral preparation, or someone is not having that much of time or patience, or not tolerating iron preparation well, maybe we can use this IV iron preparation. Moreover, yes, that is iron sucrose is well-known brand everywhere. Reaction is very low, but more visits to the hospital, and it is a cheap option, but one must think whether really it is cost effective, because patient has to come at least 10 times to the hospital, at least 5 6 times to the hospital to take this preparation again and again, and it looks like it may not be cost effective in those cases. In those cases, maybe we can go for this iron isomaltoside, that is gilazo, or this new preparation.
Hello. Hello.
Extremely sorry about the interruption.
No, sir. It's okay. You can
I think
continue.
we are back. So ferric carboxymaltose and isomaltoside. These are very good preparations nowadays available, around 2000, 3000 bucks. one dose is good enough to replace your iron stores, and just one visit to the hospital. They're very safe, doesn't have not many interaction or what you call side effects. So it looks like these are better options. So today we have.
Hello. Just
Hello.
sorry to interrupt you, sir. Can you please turn on your camera?
Just a minute. Huh?
Yeah.
Yes. Hello. So looks like oral for FCM is something which is option oral for FCM or pericarboxymaltose. With the availability of various generic brands nowadays, it has become cheaper as compared to the previous. So this can be the one thing which can give you the idea how to treat them efficiently, iron deficiency, anemia cases. So today we have discussed about the anemia management. First of all, anemia, just to summarize, anemia is something blood is less, the hemoglobin is less, erythrocytopenia is there. We see that in complete blood count, and that is why we should read it completely to get the better information. Anyone can treat, but to diagnose what is the root cause of anemia, that is very important. Most common cause in India is dietary deficiency, particularly dimorphic anemia, both anemia due to iron deficiency and vitamin B12 deficiency. To diagnose that properly, fasting iron studies and serum ferritin is important evaluation, and all iron preparations are well and good, but one must counsel them about the diet, what needs to be done rightly. The green leafy vegetables, the dry fruits, the fruits, other food material which contains rich iron sources should be encouraged. Patient should be encouraged to take those food properly and guided them rightly. Also look for excessive blood loss, whether there is blood bleeding from some other sources. And then if patient is willing to go for oral iron preparation, that is most welcome. But if hurry is there to increase, or you are in doubt whether a patient will continue the treatment for long duration when anemia is there, iron deficiency, in those cases, IV iron is safe, effective, and looks like the best option in this fast-moving world. Yes, blood transfusion can be one of the option, but it should be for the last thing when there is emergency. For any dietary deficiency or dimorphic anemia or iron deficiency anemia, blood transfusion should not be the option. I usually see whenever patient is anemic, GPs usually advise 1 or 2 units of blood transfusion. They don't even bother to see why someone has anemia, whether that needs to be treated rightly or not. We just supply with the blood and we are done with it. Then again, after 6 months, patient comes back to the same hemoglobin value, and that is why finding the cause, treating the cause is the most important thing. So that's all from me today. If any questions are there, please feel free to ask, and we'll keep coming back to you. Maybe next month we will discuss about vitamin B12 and other type of anemias and their management. Thank you.
Yeah.
Over to you.
Hello.
Yes.
Yes, sir. There are some questions are there. I will be posting one by one questions in the chat.
Yes, that will be nice. Yes, thank you. If any questions are there, please feel free to ask.
The first question I have posted.
Yes, so this question is from someone. Although anemia is a significant global issue, it is not associated with high mortality and morbidity. What is your comment on this? Thank you for bringing this, Dr. Ashwini. Looks like this is something which is halfly mentioned. Anemia is significant global health issue for sure, and it is not associated. No, it is associated with good amount of morbidity and also mortality. If you take just pregnancy related deaths, almost 50% of them are associated with directly or indirectly anemia. Morbidity, even your mental issues, how do you feel, how do you pursue things in your life, also depend upon your hemoglobin value. And it is obvious, because hemoglobin is less, you will feel tired, you will feel irritated, you will feel not good, and that not good feeling is something which is a major health issue. And that is why, rather than just assuming that it is not associated with high morbidity, mortality, one must make sure that it is a global issue. It has to be tackled right away to get this tackled rightly. Yes, thank you. Second question is, can a reduced RBC number with normal hemoglobin ever signify anemia? Very nice question. Thank you so much. RBC number is less. That does mean that patient is having anemia. If normal hemoglobin hematocrit is there, it may be because of the hemo concentration, because of febrile illness, dehydration, any other reason. If RBC number is less, yes, patient is anemic. One must evaluate the cause, hydrate them properly, and repeat the CBC. You will see that hemoglobin hematocrit is less, and one must have to treat that rightly. Thank you. Can individual with sickle cell trait develop acute painful episode under certain conditions? Thank you. Though it is not related with today's topic, but yes, one must discuss this also. Yes, sickle cell anemia per se or sickle cell disease per se, where double heterozygosity is there, they are always having this problem of acute. There are case report, and it is known that sickle cell trait sometimes can land up with acute painful crisis. So rather than assuming that can't be because of trait, though it is rare, but yes, one can keep a watch. If along with that other things are coming into the picture, like hemolysis is there, dehydration was there, and patients having typical sickle cell like crisis, one must treat them like a sickle cell disease by giving proper hydration, treating the underlying cause. And if it is repeatedly happening, sometimes one may use hydroxyurea in those cases as well. Thank you. How are iron deficiency and non-transfusion dependent thalassemia differentiate with lab tests? Thank you so much for asking this question. Very nice question. Iron deficiency anemia is iron deficiency anemia. Whenever there is low ferritin, whenever there is fasting iron studies showing iron values low, PIBC high, transferrin saturation low, it is iron deficiency anemia. When non-transfusion dependent thalassemia is there, usually it is proper thalassemia minor or thalassemia intermedia. Initial clue can be by Mendel's index, which is MCV upon the RBC count. As already discussed, MCV will be low in both iron deficiency and this thalassemia minor. But if RBC count is good, the Mendel's index will be less than 13 for patients who are having minor. And to confirm that, one must go for HB electrophoresis or HPLC. That will click the diagnosis whether patient has iron deficiency or thalassemia minor. And mind it that yes, thalassemia minor patient can also have the iron deficiency anemia. So if iron deficiency is there on blood picture or iron studies, one must treat that iron deficiency as well. Thank you.
Hello.
Yes, sir.
Yeah, we are done with all the questions, sir, now.
Sounds right.
And
yes.
thank you very much, sir, for your valuable time and sharing important insights on the topic, sir.
Thank you so much. We'll come again next month then. Okay.
Okay, sir. Okay, okay.
Thank you everyone for